Hey guys, this is Charity Stanley, and today we're talking about acute kidney injury and chronic kidney disease. So, acute kidney injury happens when there's suddenly damage to the kidney and it stops working as it should. So, this is acute kidney injury is caused by several different factors. Um, Basically, there's a rapid increase in the creatinine. It takes several days for the full creatinine increase to be exposed. The GFR is the glomerular filtration rate. This is an overall indicator of kidney function. This doesn't work. Your kidneys don't work as well when you're having metabolic problems or when you're experiencing an illness. If the kidneys aren't working, you're not cleaning out the waste products in the body. So this creates problems with waste elimination and fluid and electrolyte balance. Acute kidney injury can happen over a few hours or over several days. So when our kidneys aren't working as well, our normal kidneys need to be producing about 30 milliliters per hour of urine for good kidney function to be assured. If it's not producing that much urine, then that's called oliguria. So small amounts of urine is oliguria, and urea is when it's not producing any urine, and that is an indicator of significant damage to the kidney. So with acute kidney injury, you're going to have decreased perfusion to the kidneys. This decreased perfusion and blood flow to the kidney causes damage to the kidney and also causes additional obstruction of urine flow. Several risk factors can contribute to this. Your blood pressure being too low, you have to have at least a good systolic and diastolic pressure to be able to get good perfusion to the kidneys. If you're on a ventilator for a long time or if you're experiencing sepsis, that can cause acute kidney injury as well. And the way you need to think about kidney injury is, where is the injury happening? Is it happening pre-renal? Is it happening before the kidney? So this is different things that can impair renal perfusion. This is going to be things like dehydration, shock, or sepsis. Intrarenal problems. This is what is going on actually within the kidney. This could be an embolus, could be a thrombus from some other location, blood clot within the renal vessels, or some kind of toxins to the kidney. Post-renal is going to be related to urine flow obstructions. So the damage is due to something happening beyond the kidney on the way of the urine getting out of the body. So the pre-renal and post-renal system works both with the RAS system within the kidney to increase perfusion of the kidney and to ideally help with the problem that's happening within the kidney. So if we fix the actual issue that's going on with the kidney, then we're more likely to be able to have the kidney bounce back with minimal damage. So part of the way the kidney works is through perfusion. So adults need to be drinking about 2 to 3 liters of water each day, and that ensures that you are not dehydrated and that your kidneys have good perfusion. You have a good solid blood pressure. You're not hypotensive due to dehydration. Now, one of the most common causes of acute kidney injury is dehydration. When patients aren't drinking enough, their kidneys don't get enough perfusion, and it causes an acute kidney injury. Now, if you're working out in the heat or if you're an athlete, you may need to drink more than 2 to 3 liters a day. Now, kidney damage can happen from CT contrast and metformin. So if a patient has to have a contrast CT, metformin needs to be held 24 hours before and a minimum of 48 hours afterwards. Metformin and the CT contrast actually combine together and stop up the glomerulus, and you're not able to filter to filter the blood as well. So with kidney injury, you're going to see changes in the urine amount, the urine frequency, and the way the urine looks. You may also smell very staunch, foul-smelling urine can be a consequence of acute kidney injury as well. So this can be related to trauma. It can be related to surgery. Acute kidney injury can be due to problems with transfusions or allergic reactions. Medications, if you're taking antibiotics or a lot of NSAIDs, that can further damage the kidneys. Immune-mediated acute kidney injury. Biggest example of this is going to be glomerular nephritis. And this, remember, is from untreated streptococcal infections or inadequately treated. Patient didn't take the full course of the medication. And so the immune antibody complex will actually get stuck within the glomerulus, causing the glomerular nephritis. So we need to be asking about patients taking antibiotics and NSAIDs that may have difficulty being cleared by the kidneys. So patients may also have a history of other obstructive problems. For example, if you're having problems with the prostate, you may have issues with stopping or starting a urine stream, having to pee a lot at night, or having a history of kidney stones. This can cause damage to the kidneys and the ureters. So remember, 30 milliliters an hour, normal urine output. We need to assess for fluid overload. So when our kidney is messed up, it stops producing as much urine as it should. So those waste that normally get removed, the nitrogenous waste, start to increase within the blood. As these toxins increase within the blood, often patients will have changes within their level of consciousness. Now, if the toxins aren't getting taken out by the kidneys, then the lungs will try to get rid of the toxins by speeding up the respiration rate. Now, this all leads to fluid retention and increased swelling and a mean arterial pressure below 65. That means the kidney is not getting the perfusion that it needs. And patients will often be tachycardia. So we need to keep doing strong evaluations for vital signs and make sure we're treating that blood pressure and treating hypoxemia, low blood oxygen concentration within the lungs. So when the kidneys are not working correctly, the creatinine and the BUN elevates, GFR decreases. In acute kidney injury, because it happens so suddenly, you don't really have many blood changes or anemia. However, as the BUN, the nitrogenous waste, increase, the toxins will actually cause blood cells to lyse, and that will contribute to further anemia. So there's several imaging assessments that you can do to be able to look at the kidney and figure out what's causing it. And you also can do a kidney biopsy. These are very painful and they must be done in IVR due to increased risk of bleeding. So what do we need to do as nurses? We need to avoid hypotension and treat hypoxemia, work on maintaining normal fluid balance, reduce exposure to nephrotoxic agents and drugs. So an example of this is CT contrast, especially in the presence of metformin. Nutrition, we need to make sure they're having a nutritionally sound diet. And often we will have difficulty with protein breakdown within kidney patients. And so they have a set amount of protein that they can have daily. So protein breakdown is slowed with stress, illnesses, and really anything that increases cortisol levels. You may need nutritional supplements since things are being dumped by the kidney that shouldn't be dumped by the kidney. And if the kidney isn't picking up and cleaning out the waste, at some point you need to consider something to help get rid of these toxins, looking at dialysis. So, and with dialysis, there's really three types. One is peritoneal dialysis, and this is where patients can be at home. Typically, it's a machine that they will hook themselves up to at night, and it will cycle fluid into the abdominal cavity that causes osmotic shifts and removes the waste products. And then it will suck that fluid back out and put in fresh fluid a little bit later during the night. So patients that are on peritoneal dialysis tend to be able to stay at home for a longer period of time. Eventually, that's not going to be strong enough, and they move up to hemodialysis. Hemodialysis is where you have a shunt in your arm, and they will pull blood out of the arteries, process it, and put it back. I'm sorry, I have that reversed. Pull blood out of the venous system, process it, clean it, and then push it back in. And so finally, we have continuous hemodialysis. This happens within the ICU, and you're hooked up to it 24/7. So this allows for slower fluid shifts, and it allows for stabilization of the fluid and the electrolytes. Chronic kidney disease. Chronic kidney disease is progressive. It happens over a long period of time. Eventually, your kidneys stop working completely, and you either choose to go under to be cared for through dialysis or through continuous dialysis within the ICU, or you look at getting a kidney transplant. Azotemia, this is where the nitrogenous waste are not being cleared out of the body, and so they're increasing in the blood. Uremia, this is an increase in urea. So as the body starts retaining urea, that urea will try to get out of the body any way it can. So one way it tries to get out is through uremic fetor. That's going to be a very, it smells like acetone breath. And then uremic frost. This is actual white crystals that will start to emerge out of the skin. Now, interestingly, birds cannot pee and poop separately. So birds only have one hole, and when they poop on your car, you're going to see white and you're going to see brown or black, depending on what they've eaten. And so the white is actually the urea that would be eliminated from their body if they were human through urine. But you do see urea as like a white substance, even on your car windshield as well. Uremic syndromes often involve paresthesias, feeling weird things, random neurologic issues, and also having shortness of breath. Chronic kidney disease happens over a long period of time. It's usually a minimum of 3 months of issues. So our stages are going to be based upon the glomerular filtration rate and the albumin levels. So stage 1 is the least kidney damage. Stage 5 is the worst. Stage 5, a transplant is your only hope for cure at that point. So chronic kidney disease causes several changes within the kidney. You're not going to see really any symptoms from kidney damage until you have lost up to 75% of the function. So one of the first things that happens is you lose the ability to concentrate urine, and the body loses the ability to be able to get rid of sodium. So you increase the amount of sodium in the body, as we've talked about. What follows salt? Water. So you're going to have an increase in swelling. Whenever your sodium gets messed up, your potassium gets messed up too. And so, since you can't get rid of sodium, you're not going to be able to get rid of potassium either. So, you have both hypernatremia and hyperkalemia. Patients may present with Kussmaul respirations, and this is going to be the rapid changes in the breathing rate and depth, and this is due to acidosis. And so going back to endocrine system, so the increase in parathyroid hormone is going to cause an increase in blood calcium because the parathyroid hormone steals the calcium from the bones. Also, the parathyroid hormone activates vitamin D in the kidney to go to the stomach and allow more absorption of calcium. Decrease in immunity often slows the white blood cell functioning, and so your immune system is compromised as well. Other changes that happen is going to be cardiac changes. You may have hypertension, may have an increase in low density lipoproteins, develop heart failure, and you can end up with a uremic cardiomyopathy. So this is the leading cause of death in end-stage renal disease, and the pericardial sac can start to absorb some of that uremia and cause inflammation and irritation and pericardial rubs due to the irritation of the sac by the urea. Additional changes can happen to your cognition as well. And late stages of chronic kidney disease, you're not going to be able to think as well. And decision making becomes more difficult. There are a ton of different diseases that can affect and subsequently contribute to loss of kidney function. Some of the big things are going to be hypertension is going to be one of the biggies, and diabetes. Now, one thing that we see that is concurrent with kidney disease, African Americans are more likely to have both hypertension and diabetes. We really don't know why, as we've talked about before with some of the health disparities. Treatments may also be a little different. The glomerular filtration rate, GFR, is going to be a different numerical scale for African Americans than it is for Caucasians as well. So about 15% of all Americans are thought to have chronic kidney disease, but most people don't realize that they have the disease. Again, because it takes about 75% of the damage to happen before you even realize you have symptoms of this. So major dietary adjustments can help control chronic kidney disease. And this is going to be making sure that we're eating foods low in sodium, controlled protein levels, and low in cholesterol. It's important that smoking cessation happen and alcohol is limited to within kidney disease. When there's a buildup of urea, people report a metallic taste within their mouth. Their energy level decreases, and they often get confused and have symptoms of encephalopathy. So this is also going on with the other disease comorbidities that the person has. Neurologic changes can happen from chronic kidney disease. Seizures are pretty common, and these can be in the presence of encephalopathy and can cause encephalopathy and can cause some weakness. Cardiovascular symptoms can also happen, like fluid overload, hypertension, or heart failure. Respiratory symptoms. Often you're going to have fluid overloads. You're going to hear crackles, uremic fetor, that uremic acetone type breath, and faster breathing, the Kussmaul respirations. Hematologic symptoms will be abnormal bleeding, within the body and anemia. Skeletal system is going to be affected through osteoporosis. Urinary symptoms, you're going to have sediment, and you may actually see things precipitate out and settle in the bottom of the urine cups when you're getting, or Foley bags when you are getting samples. Skin symptoms is going to be skin darkening. It will start to look more bronze. You have a yellowish color as well. The skin stops producing as much oil, and this leads to itching. Uremic frost is often found on the face and in the person's eyebrows. Looks like little crystals within the eyebrows, and in their groin and armpits. So people with kidney disease often are having problems with anxiety and fear of the unknown. Need to recommend that they use good, strong coping mechanisms and have family support as well. Laboratory assessment of chronic kidney disease, creatinine and BUN, both of those elevate in the presence of kidney damage. Sodium, potassium, calcium levels, phosphorus, bicarbonate levels. Bicarbonate is involved with the acid-base balance within the blood. Look at the GFR to see how much the glomerulus is actually filtering each minute. Imaging, we may need to do x-rays. And we often will find on kidney scans, kidney CT scans, that kidneys shrink in the presence of chronic kidney disease. So big things we need to watch out for is that our patients aren't experiencing fluid overload, that we're making sure that their cardiac function is getting better, looking at nutrition and using supplements, changing the protein level in the diet, having sodium and potentially potassium restrictions, preventing injury, because with these electrolyte and fluid balance issues, patients can become very dizzy post-dialysis, and we need to monitor for hypertension and for fluid overload. So if our kidneys aren't working, there's several things that we look at. First off is going to be who is going to be able to be healthy enough to handle dialysis. Dialysis is a very exhausting procedure. During dialysis, they are taking blood out of your body, changing it, and putting it back in your body. So we have to make sure that patients have anticoagulants on board, because as blood pools, it's likely to clot. Have to have a specific vascular access, and has to be mature before they can start the dialysis as well. Now, often you will hear codes be called when a patient is in dialysis, and this during dialysis, you're messing with the fluid and electrolytes, you're changing things up, you're messing with the fluid balance. And dialysis frequently has fatal codes. So patients who are in dialysis already are sick, have multiple comorbidities, potentially have kidney-related cardiomyopathy, and so multiple organ systems are already struggling. So it's important that patients realize that dialysis is a stopgap and it is life-saving. But with that said, it often becomes a lifestyle and is a very difficult thing for the family, having to go in for potentially 5 days a week for 4 to 5 hours each day. So patients may experience a change in mental status, and this is due to sodium changes due to the dialysis. Now, these machines are much better than they have been in the past, but it is still possible to be infected with hepatitis B, C, or HIV. Now, if you're having dialysis, um, your medications that you have taken that morning will literally be filtered out. So often many medications are held until the patient returns from dialysis. And if you need to hold the patient's blood pressure medicines prior to dialysis, because if you go ahead and give them the dialysis and they pull the fluid off, it can cause problematic hypotension during dialysis. Peritoneal dialysis. So peritoneal dialysis is going to be something you can't go really from hemodialysis backwards to peritoneal. Um, and so with peritoneal dialysis, you hook up at night. You're still free to work during the day. Complications can include changes in your blood pressure, confusion, dizziness. And if you're having to do it in the hospital, that can be more restrictive of your lifestyle than if you have the machines at home. The machines at home are kind of like patient CPAPs, and they're able to just cycle during the night. Here's an example of how peritoneal dialysis works. So at first, the solution's being pushed into the body. It sits within the peritoneum, and then the bag is lowered, and that allows drainage to happen of the waste products. A new bag will then be hooked up to be flushed into the peritoneum again. And after it's sat for the appropriate amount of time to cause the osmotic shifts, then that bag is then lowered, allowing the waste products to escape. Kidney transplantation. This is our Hail Mary. This is our last result, last thing we can really do to help people with kidney disease, but they have to be strong enough to be able to survive the procedure. So our patients for kidney transplants, they need to advance kidney disease. They need to have a reasonable life expectancy, need to be healthy enough to be able to live through the procedure. In the US, you are able to get on the waiting list when your GFR drops below 20 milliliters a minute. Remember, we said 30 milliliters a minute is what we need for good, healthy kidneys. Our donors can be living. They can be someone who's related to you, someone who's not related to you. Similar to organ transplantation, you have to have a match. You really don't have to match the size of the kidney as much because they're not going to take out the bad kidney. What they do is literally just change the plumbing, the blood vessels, and hook up the new kidney in the front of the body. So you can also have patients like organ donations, and those can be transplanted within several days of the patient's death. And you can even have cadaveric donors. The highest rate of graft survival, though, is the living donor because you're literally taking it from one operating room into another to hook it back up. So it is working constantly. Preoperatively, we need to have immune system studies to find out the HLA antigens so we can help prevent rejection. Dialysis needs to happen within 24 hours before surgery to give the kidney time to figure out what it's doing and start working again. And often we'll have blood transfusions prior to surgery too. So operatively, as we talked about, they will often place the new kidney in the front of the body instead of removing the old kidney. So here's a picture of how they go about doing that. So after the kidney transplant, we need to keep assessing the urine output for the next 48 hours to make sure that the urine output is continually increasing. We may have to do continuous bladder irrigation, that's CBI, to help get rid of the blood that is within the kidney and within the urinary tract. And we will definitely have to do immunosuppressive drugs. This is cyclosporin. This helps turn off the immune system to decrease the likelihood of rejection. So there's different types of rejection. First type is hyperacute, and this is within 48 hours of the kidney being put in. Okay, acute rejection is the most common type. It is averaged about week 40, almost a year. And with this, we treat it by increasing cyclosporin for acute rejection. Chronic rejection happens over months to years, and that we control with prednisone and cyclosporin. So there has to be a large amount of education that happens prior to a kidney transplant to make sure the patient and the patient's family are able to deal with the changes that it will bring. Self-management of kidney disease and kidney transplantation, you need to make sure the patients understand once they get a new kidney, this isn't free gratis to go do whatever they want. They still have to take care of that kidney. They need to know what kind of diet they need to be eating that's most healthy for the kidney, and make sure that they're adequately hydrated and are not using salt. So big things to evaluate: making sure patients have a good nutrition status, trying to prevent them from getting infections that could potentially infect the kidney or cause sepsis, and prevent the slow complications of chronic kidney disease. And patients with kidney transplantation often are very anxious about the transplant. And so you need to report an absence if they aren't anxious or depressed, because often they're not sharing something that needs to be shared. Okay, thank you guys very much. I will see you on the next.